right, good morning, class, and um, I'm Loretta Richardson, and today we are going to discuss inborn errors of metabolism. Some of the key things that we want to be thinking about when we talk about inborn errors of metabolism is how do you think this is going to affect lifestyle, newborns, family, and everything else? All right, so our objectives that we are going to be talking about today is first thing we're going to start off with is your overview of metabolism. Then we're going to look at what the inborn errors of metabolism is. Review some types. There are over 1,000 of them, so I'm not discussing them. We're going to talk about 5 of them. All right. Describe the genetic characteristics of most of the IEMs. Again, I'm gonna touch on 5 different ones today and some key concepts for testing and treatment related for these inborn errors of metabolisms. All right, and then we're gonna talk about education as the FNP. What role do we play when we are working with these family members of these newborns? All right, so first thing we're going to talk about is metabolism and enzymes. So we need to know what our metabolism is, and there should be a brief review. So we know it's the chemical reactions that occur within the body, within our cells, organs, and for organisms, right? Our food is broken down into smaller substrates to be utilized by the body. In order for this to happen, each one of these substrates has specific enzymes, right? So these enzymes are, cofactors. They allow these reactions to occur. All right, so that's some of the kind of things you want to be thinking about as I go through this presentation with you. All right. So just a brief overview of what enzymes do for the body, and then what the metabolism is, just kind of getting that brain going. So knowledge check will be checked at the end, and here are some of the questions that we're going to go through at the end. So we're going to talk about, and you should be able to answer them, what are inborn errors of metabolism, what is the role of enzymes within the body, and what are the 5 IEMs discussed during this presentation. And I'll give you a minute to either jot that down or just take a picture or memorize it. All right, so what are inborn errors of metabolism? All right, well, they are rare genetic conditions that occur. And some interesting facts that I have found is that in 1908, Sir Archibald Gerard, he came up with that term of IEMs, inborn, and we only had 4 disorders. Currently, we have over 1,450. So you can see the vast majority of, we have a lot of them out there, okay? But they are rare. It's like 1 in 800, or global is, 50.9 in 100,000, so not too many. All right, and then again, what it is, they're either a defect in the enzyme, missing the enzyme, or the transport protein is not there. So they have a different one that affects the metabolism of carbohydrates, proteins, and fats. All right, and so in understanding what carbohydrates, proteins, and fats do is pretty important. When it comes to our carbohydrates, they get us from point A to point B, right? And then we have our proteins. Those are our building blocks of our body, our immune system, our hair, our skin, and our nails. And then our fats are they're also used for energy. They can be used for energy. They're more dense. They're harder to break down, but they're for hormone regulation. They are also for, again, used for energy. cushioning, protection. They do play a vital role to our body. All right. So one of the big things about these inborn error of metabolism is the mechanism is unknown. We don't know exactly what's happening. It is gene mutations. They're autosomal recessive, usually X-linked. There's no true treatment. You got managing it, and then dietary restrictions, and then enzyme replacement. They have a few enzyme replacements that have been FDA approved, and that will allow these individuals, these newborns, with it. All right, so just giving you this overview of the inborn errors of metabolism. So your protein metabolism disorders, your fatty acid oxidation disorders, your carbohydrate metabolism disorders. And in today's presentation, we are going to talk about PKU, MSUD. We are going to talk about galactosemia, and then pyruvate metabolism disorders. All right, so I highlighted those in the next couple of slides. All right, so here is another little breakdown of your carbohydrates. You have your simple and you have your complex. All right, so your simple, your monosaccharides, your disaccharides, your polysaccharides. And then on the other side, we have our amino acids. You have your essentials and then your not essentials. Your essentials have to be eaten, they're in our diet, and then they help make our non-essentials. So I know, again, just a little bit of review. But if you're thinking about the inborn errors of metabolism, we're going to talk about PKU is your phenylalanine. Galactosemia is your galactose, okay? So just think about some of the inborn errors of metabolism, and it'll kind of put you on thought process if you have these newborns that, okay, so galactosemia, they're not going to be able to do something with galactose. So they are kind of equivalent to things. And then some of the other ones are just your straight up amino acid ones. All right, so PKU. All right, so when we're talking about PKU, PKU, as I just showed before, is an essential amino acid. But what's happening is we're missing that enzyme. It's deficient and it cannot be broken down. So it's a protein metabolism disorder of phenylalanine. So autosomal recessive. So we can't convert it over, which happens to have a buildup in the body. When we have that buildup in the body, amino acids, when they break down, they can have toxic leftovers. If anybody has worked out before as an adult and you break down some muscle, you get this lactic acid buildup from that breakdown of muscle. And I know babies are not, in our newborns when they have PKU, not working out, but you can just understand that lactic acid is a toxin to the body. All right, so some of the clinical manifestations, there is a gamut of clinical manifestations when it comes to these inborn errors of metabolism. But one of the big ones that you'll see with PKU is tyrosine is needed for melanin, which is your skin, right? And then, so these children, these infants, newborns will have hypopigmentation with the hair, skin, eyes because they're not making that melanin, all right? You're also going to have an intellectual disability, autism, seizures, some motor deficits, severe ones. Okay, and then again, there's going to be some feeding difficulties because they're not breaking down and they're building up toxins. All right, the next one we're going to talk about is pyruvate dehydrogenase complex deficiency, PDCD. And just to go back to a little bit with our enzymes and another quick review, if you see anything with ACE at the end of it, that's an enzyme. So just a little quick refresher of a little bit of biology type stuff. All right. So this PDCD is a X-linked mutation. All right. And then we're having a disorder of energy metabolism. Pyruvate is a byproduct of glycolysis. And if you see that word glycolysis, you should be thinking glycogen, glucose, kind of in the same ball field. So you're going to think, oh, metabolism of carbohydrates. So just kind of one of those, if you need some good remembrance, okay? What happens with this is you have about 1 in 42,000 births in the U.S. Usually they're diagnosed between 12 and 31 months, maybe not right away. And it is a major cause of lactic acidosis, which I kind of explained when we had this breakdown. We're not using things appropriately. We build up toxins. Lactic acidosis is one of them. 90% of these children could die by the age of 4, all right? And again, your clinical manifestations for this it varies in nature. There's a lot of different possibilities. Again, one of the ones you're going to see is you're going to have those feeding difficulties with all these IEMs. Overall, the newborns are going to be ill appearing. So sometimes they have to rule it out first because, again, they're not feeding properly, they're not absorbing properly. Carbs, proteins, and fats are vital for building life, so we need them in a lot of nutrients. So just some things to be thinking about as we're going through. Okay, so if they get so much lactic acidosis, again, it's toxic to the body and it can be fatal. They can have, with all this buildup, brain malformation, hemiplegia, they may appear like a Guillain-Barré-like presentation. So these are just some of the things that we need to be looking at. Next one we're going to discuss is our galactosemia, right? Again, it's another autosomal recessive, all right, and it's another carbohydrate metabolism disorder, and our body cannot convert galactose over to glucose, all right? We're missing that GALT enzyme, galactose 1 phosphate uryl transferase, all right? So we're missing that enzyme and we can't convert it over. Some of those clinical manifestations that we are going to have are, you're going to see it when they start breastfeeding because that's where they're getting those milk products. So they're feeding difficulties, they'll be vomiting. They also may show hypoglycemia or low glucose levels because things aren't converting like they should be. Diarrhea, jaundice, lethargic, life-threatening if it's left untreated, and then eventually we have some developmental delays. All right, the next one we're going to discuss is our maple syrup urine disease, another autorecessive. And what that one is doing, it's affecting that degradation of the branch chain amino acids in general. All right, we do have this 5 different types, right? Classic, intermediate, intermediate, and then thymine responsive, and dihydroliposilene. I know I said that wrong, but just so you know, it's not just one MSUD. There are actually 5 different types, and they do vary. But classical is the most common, affecting 90% of our affected newborns. This one needs that timely intervention. What happens is because it's not breaking down those branch chain amino acids, we get a exceedingly high level of leucine, which is could be toxic to the body. So the best we need to do is it needs to be diagnosed because of that. Why it gets its name, like maple syrup urine disease, is because their urine smells like maple syrup because of that high concentrations of that the leucine. Okay, it can be fatal. Again, you're going to have those nervous system problems, feeding difficulties. One of the key signs for any of these IEMs, as you can see, is your feeding difficulties. And then they could go into ketoacidosis. So keto is fat, and then they become acidic because of the breakdown of fats. Right? And then eventually you may see some mental retardation in just about even all of these IEMs. All right, urea cycle disorder, very interesting one, but this is another, it's in a different area. It is another waste product from the metabolism of proteins. And one of the byproducts of protein is ammonia. But here we cannot remove the ammonia from the bloodstream, right? So again, we're either missing the enzyme or it's lacking that transport. And the reason why that is because here on this slide, you can see we have a variant. This can be, I know this is a very complex slide, but if you look at all of these, you have the different types and the different ones because you could be missing a enzyme in any of the cycle. So you can be missing it, anywhere you see the word ACE is an enzyme. So as you can see, the X's, in carbonyl phosphate synthase 1, you're going to have hyperammonemia type 1. All right. And then on the other side, and then just that cycle. So for this particular IEM, it's really going to be dependent on which enzyme is defective in what you're going to see for your clinical manifestations. So very interesting, and it could be so many different things when it comes to this. All right, so again, it's going to be very variable depending on which enzyme is defective within the cycle. So non-specific, but one of the biggest thing is your failure to thrive. And because of that urea cycle and that buildup of ammonia, the liver is going to be highly affected. So you're going to have those hepatic and renal conditions that may be your first signs of something's not right. All right, so this here is just looking at which ones are going to affect our liver. And why is that important? Because if you think about our liver in general, it is our filter system, right? So some will affect your liver and some may affect it a little bit. And that's going to make a difference because the ones that are going to affect the liver, you will see more of your, your jaundice, hepatomegaly, right? So those are just some of the things to be thinking about. It can have some, so you have some that kind of go through. So this was just that overview of looking at, and again, there's a whole lot more, but we're talking about, but there's your urea cycle defects, except for the one is not going to hurt the show up in the liver disease. Your glycogen storages are going to be shown in your liver. So just kind of a little quick overview of which ones are going to affect your liver and which ones won't affect your liver. All right, so now we talked about them, and now we're going to go into some screenings and why is it important for screening these little infants. All right, newborn screenings kind of established 1930s, and then we advanced for IEMs in 1963. So relatively fairly new thing. So, and Wilson and Junger published in the 1986 the 10 rules for the inclusion, right? When we should be looking at this. So there was 10 different things that says if the newborns are having this, this, and this, we need to be screening for these IEMs. And as we know, we have our dry spot testings. And again, it has a great test for several of the IEMs. So very simple heel prick is allowing us to test. PKU is one of them. All right, but here's the one thing with these, if we test too early, there may not be enough buildup and be not enough of the metabolites from the buildup of the toxins to say that this is their that they have this IEM. So if we test too early, we can get a false result, right? And this is kind of what a lot of our tests that we have, so we need to be thinking about that. All right, so very important on time sensitive. All right, and then we have a biochemical test. So these are other ones. So you're going to look for your urea, your electrolytes, your liver function test, your blood gases, right? Blood gases is pretty important because as we talked about the lactic acidosis, these newborns are going to become metabolic or respiratory alkalosis, acidosis, depending on which IEM. Right, so then blood glucose, plasma ammonia, and then from there we want your metabolic screenings, okay? So they're going to look at the plasma amino acids, a carnitine profile, urinary organic acids, and then urinary glycosaminoglycans. And then from there we go down to more specific metabolic tests based on what the results showed of that. All right, so there's a lot of different things that we have. All right, and then here is our blood glass. I thought this was very interesting to kind of provide some information on that. So if we suspect that this newborn has an inborn error metabolism when we do our blood gas, this is a nice little chart that can kind of help steer us in the right direction, right? What's going on. So kind of breaks it down a little bit for what we may see in our blood gas. So again, you can see your maple syrup, right? Metabolic acidosis, you got your respiratory alkalosis, okay? With maple syrup urine disease. And then on the other side, you have your mitochondrial disorders or disorders of pyruvate. So just kind of a nice little quick little chart I thought was interesting to share so you guys can see how important blood gases are. All right, so now we're going to talk about some of our treatment, and then based on what we were kind of saying, a lot of it is food, right? So we need to be thinking about how we're once we kind of get this diagnosis, what are we going to do? So one of the best things is if we can replace the enzyme. So in the article that I found by Han et al. In 2023, we actually have 15 approved ERTs, enzyme replacement therapies, by the FDA. However, it is very critical on dosing. So the dosing has to be accurate based on all the factors. And so that was, it's very interesting that we can do that, and that is just showing how important enzymes are for the body. All right, so going into treatment, a lot of it is, like we discussed, as I mentioned earlier, food buy. So PKU, you want to limit those foods with phenylalanine, milk, cheese, nuts, beans, fish, peas. Those are some of them. For PDCD, one of the best one was the keto diet. So I know probably heard of the keto diet. So keeping it more keto friendly, even for this, has shown to be improvement. For the galactosemia, we got to avoid those lactose type foods. So obviously, if they're breastfed, we're going to have to change. So there's got to be dietary changes that occur for these newborns. For the MSUD, again, another one is dietary. There's also been some research that says vitamin B1 and then possibly a liver transplant, but that is going to be further down the line. So the biggest thing with the urea acid disorders is lowering the ammonia in the blood. So the lower the protein diet, the lower the ammonia. Okay, so these are just some key treatment options. So a lot of it you can see is going to be food-based for these newborns with IEMs. Some of our differentials, like as we go through and we see, you're going to have your malabsorption, malnutrition, diabetes, some congenital infections that's causing this sepsis, because you got the jaundice, hypoxic ischemic encephalopathies. Again, they're going to have that if they have that elevated ammonia level. Another differential is your duct-dependent cardiac lesion or congenital adrenal hyperplasia. So we all know what our adrenal glands do. So it could be something going on in that whole process. So these are just some common differentials. There are actually a whole lot more because it really is dependent on the IEM. So what are some important education material that we need? We have to explain to the family that they are a rare genetic condition, not that they didn't do anything, the importance of the screening, and then further testing, the metabolic testing, the biomarkers, the the blood gases, to like really hone in on what's going on, of why the newborn is ill appearing, because that's one of the classic signs, is an ill appearing infant. All right, and then your treatment options. What are your treatment options is really your diet restrictions or additions, enzyme replacements, right? And those are the best treatment options. And then obviously if transplant is an option, that can definitely be. And then the biggest thing you're going to apply is education. We need to provide the resources and education to the family to allow them into support groups, the dietitian who specializes in IEM, so they know exactly, because believe it or not, there are so many different foods that we don't think has this, this, and this in it, but it does. So these are some important things that we need to be thinking about. All right, so in summary, they are rare inherited genetic conditions affecting either your carbs, proteins, or fat metabolism. All right, the metabolic process. There's over 1,400 of them. It's either avoidance of certain foods or enzyme replacement is the best treatment. And definitely, if it's undiagnosed, can lead to severe complications or be fatal for these newborns. So diagnosing by our screenings are very important. All right, I hope this was interesting. Hope you learned a little bit about IEMs. All right, and now we are going to do our knowledge check. All right, so what are inborn errors of metabolism? You got it. Genetic autorecessive error of metabolism of either your carbohydrates, proteins, or your fats. All right, and what is the role of enzymes within the body? They play a gamut, but generally they're substrate specific to allow for reactions to occur. And what were the 5 main IEMs discussed during this presentation? PKU, urea cycle disorder, PDCD, galactosemia, and MSUD. Those are my references. And thank you. And I do hope you enjoy this presentation on IEMs. Have a great day.